Welcome everyone. I would like to introduce my PhD thesis topic, which is the importance of pancreatic exocrine insufficiency in pancreatic diseases. My name is Orsolya Eperjesi. I work as an internal medicine doctor at the Tor Reference Hospital, and I am also a first-year PhD student. My vision is on optimized management of patients with pancreatic exocrine insufficiency, and my mission is the optimization of pancreatic enzyme replacement therapy management in early post-acute pancreatitis patients. To achieve this, I have two specific goals. The first one is investigating the effects of pancreatic enzyme replacement therapy after acute pancreatitis, and the second one is investigating the predictive risk factors of pancreatic exocrine insufficiency after acute pancreatitis. So my first project is investigating the effects of pancreatic enzyme replacement therapy after acute pancreatitis. As more patients survive from severe acute pancreatitis, it is important to see how those patients live and how one episode of acute pancreatitis changed their day-to-day activities. A recent meta-analysis by Huang et al. Demonstrated that the prevalence of PEI during an index attack of AP is approximately 60%, implying a significant majority of patients will have at least some degree of maldigestion during their initial hospitalization. Although this frequency falls during the follow-up, persisting in a minority, and the PEI prevalence is still about 30% after a 3-year recovery. So there is a high prevalence of PEI in patients with acute pancreatitis, both during their initial hospitalization and in the long-term follow-up. As we all know, PEI can cause several intestinal symptoms, such as abdominal pain, bloating, cramping, increased flatulence, diarrhea, steatorrhea, and weight loss. And all these pathological changes seriously affect the quality of life of patients with pancreatic exocrine insufficiency. Furthermore, a large cohort study found PEI to be a strong independent risk factor of mortality. Although the clinical benefit of pancreatic enzyme supplementation is not known, evidence from other diseases associated with PEI strongly suggests it will be viable. Therefore, my aim is to investigating the effects of pancreatic enzyme replacement therapy in acute pancreatitis. So we ask the question, does PERT decrease the PEI symptoms after AP? To answer this, we will use the PICO framework, where the population is patient after acute pancreatitis, intervention is pancreatic enzyme replacement therapy, comparison will be standard care plus placebo or no intervention, and the outcomes will be several PEI symptoms and laboratory parameters. And my hypothesis is that PERT can decrease the symptoms after AP. As I mentioned before, even a single episode of acute pancreatitis can cause PEI and have an effect on long-term quality of life. Therefore, optimization of pancreatic enzyme replacement therapy in early post-acute pancreatitis can have an important role of management of patients with acute pancreatitis. We conducted the systematic search in ST databases at the beginning of November, and we used the search key that you can see on the slide. And after the systematic search, we got more than 3,000 articles. And after the duplication removal and the title abstract selection, it became 212 articles. So we finished the title abstract selection, and currently we are working on the full text selection. My second project is investigating the predictive risk factors of pancreatic exocrine insufficiency after acute pancreatitis. As I mentioned before, there is a high prevalence of PEI after acute pancreatitis. It can be even a 30%. Less is known regarding which patients need to be screened for PEI after an episode of AP. However, testing every patient after acute pancreatitis is still not feasible in the real clinical practice. Although that by identifying more patients who could benefit from the therapy, we can help prevent many complications associated with malabsorption and malnutrition. Therefore, my aim is to identify the risk factors of post-acute pancreatitis PAI. And my question is that what are the predictive risk factors of post-acute PAI? We will use the PFO framework in this meta-analysis, and my hypothesis is that there are risk factors that can predict of post-acute PAI. And if we can find them, it may help alert the clinicians for the earlier detection and treatment of patients with post-acute PAI. Here you can see my search key, and there were already 2 previous meta-analysis regarding the topic, and there is also another ongoing project registered to Prospero. Here you can see some of my key articles. As you can see, we will investigate several risk factors, for example, etiology and severity of AP, necrosis ratio, and localization of necrosis, but there are many others that we would like to investigate. As an overview, I have 2 ongoing projects. The first one is investigating the effects of pancreatic enzyme replacement therapy after acute pancreatitis, and the second one is investigating the predictive risk factors of pancreatic exocrine insufficiency after acute pancreatitis. Both projects connected to the pancreatic exocrine insufficiency because we see many patients suffering from the consequences of PEI in our department. And as Rosalind Franklin said, science and everyday life cannot and should not be separated. Thank you for your attention.
Thank you very much, Orsi. Very nice talk. Are there questions from the audience?
Thank you, Orsi, for your presentation. It was amazing. So working at a pancreatic center, the prescriptions for PERT has been increased, and I was wondering, what do we know about the safety of it? Thank you.
Thank you for the question. Recent UK guidelines concluded that there isn't any significant complications associated with PERT. However, guidelines for AP-related PI does not exist yet, and until now there were only 3 randomized control trials where they investigated the effect of PERT in acute pancreatitis. The last one was in 2040, and it found that PERT is well tolerated and can safely used in acute pancreatitis as well from the first day of refeeding. But further SCT are needed, and if we will have enough data, we also want to investigate the side effect of PERT in acute pancreatitis as a secondary outcomes.
I would like to congratulate you as well for your presentation, and I wanted to ask you, what diagnostic tests do you use to diagnose pancreatic exocrine insufficiency?
Thank you for the question. It is very hard to answer because there isn't agreement regarding the most suitable diagnostic test. There are many diagnostic tests, but a single accurate and widely available test is still not exist. Maybe the most common used diagnostic test is the fecal ALS test. It has many advantages. But for example, when we measure, but it has also disadvantage because, for example, when we measure the fecal elastase level in the stool, the patients should eat a normal diet, which is very unlikely that patients during the early recovery phase after acute pancreatitis will eat a normal diet.
Thank you very much. I have also a question, so I would like to ask you, as regard of acute pancreatitis, how early would you introduce enzyme supplementation and in which dose?
Thank you for your question. There are several articles. There are articles where they start the enzyme supplementation during the hospital admission from the first day of oral refeeding, but there are articles that they start the enzyme supplementation at the discharge or just during the follow-up. We will include all the articles. As I mentioned, there isn't guidelines for the EP-related PEI, so there are more questions than answers, I could say.
More questions? No? Thank you very much. No? One more?
Congratulations. I wanted to ask you if you also considered to investigate the effect of PERT in chronic pancreatitis, not only the acute.
No, we are focusing for the acute pancreatitis, so we would like to investigate the effect of pancreatic enzyme replacement therapy after acute pancreatitis, and we will definitely exclude those articles where they investigate the patients with chronic pancreatitis.